Thank you, sister. It was really a wonderful story of using palliative care as the frame in a really complex environment, and we'll look forward to hearing a little bit more about that. Next is Jody Chrastek, Dr. Jody Chrastek, who is a Pediatric Advanced Complex Care Team Coordinator for Fairview Home Care and Hospice. Jody.
Thanks very much for inviting me here today. And just to let you know the stories I'm sharing, I want to say thank you to the families for letting me share them, and I have no conflict of interest. It certainly takes a village to care for a seriously ill child at home. And just take a minute to look at the picture here and see all the different balloons. These children have so many people involved in their care. But before we start talking about our program, let me give you some information. Pediatric palliative care is for children who are not expected to reach adulthood. So that means some of our children are on our program for hours, some of them are on for years. The number of children dying is decreasing. That's great news. We're doing wonderful medical care and saving these children. When I was in midwifery in Scotland, any child born before 27 weeks was considered non-viable. That was 10,000 years ago. And now we're saving babies at 22 weeks, but these children have complex healthcare needs. And so we have many children now who could benefit from pediatric palliative care who have these complex medical needs. And pediatric palliative care has been shown to do cost savings 11% per month and a 32% reduction in average number of hospital stays. And we know no child wants to be in the hospital and no family wants to stay longer than we need to. So let me tell you about our program. I work for a Fairview Health Service, nonprofit, full-spectrum healthcare system in Minnesota based out of the Twin Cities of Minneapolis, St. Paul. We have an urban and rural component. And in 2013, because of changes in the healthcare environment, the Pediatric Complex Care Team was started. And we're growing by cross-training clinicians. The Pediatric Advanced Complex Care Team, or PACT, is our interdisciplinary team, including doctors, nurses, professionals, child life, particularly for children, and families as we look at that. But then when we go out into the community, we extend that team to include the schools. Many times the school nurses are taking care of these children at school but have very limited information and aren't included in the care team and planning for the children. And should the DNR be allowed in the school or not? This is a controversy. And so by bringing them into the team, we can provide really extensive good care for children and bringing the county workers as well as the religious community, the daycare, and helping to work across the trajectory. These children move from home to hospital and back and forth. So we want to be able to help them. I want to introduce you to Jenny, whose child, Scarlett, died on our program. You'll see Scarlett's picture in the back.
Hi, my name is Jennifer Wagner, and my daughter, Scarlett Wagner, was on hospice for about 1.5 years. She had a severe neurodegenerative syndrome known as Schindel-Gideon syndrome. During our time on hospice, I would say it was a really powerful experience, something that was unexpected. It was very scary at first, not knowing who was coming in, what this would mean, if this was giving up. We quickly learned that it was primarily just a wonderful support network and something I wish we'd had much longer through her life. I'd say the different roles within hospice, from nursing to chaplaincy to social work, are all very beneficial in different ways. The nurses, are very supportive of the family and the children going through the process and what comforts there are. The chaplains with the spiritual component, and then the social workers can provide an entirely different perspective that I guess I didn't realize would be as beneficial as it was to our experience.
So that collaboration is so important as we look at that. Often our families say, oh, we don't want to speak to social worker. Those are people who take our kids away from us. And so we have to clarify that, and how do we do this? We do this through collaboration and developing those collaborations across silos. With our private duty agencies, a lot of our children have extended hour nurses there who are there for 8 hours, and they've been with the families for a long time and develop a deeper relationship. And so we need to work with them along with the multiple providers. Many of our children have 5 or 6 providers, a pulmonologist, the nephrologist, the gastroenterologist, and on and on. So we have 3 separate healthcare institutions within the Twin Cities. And so there's a lot of care coordination that needs to happen to collaborate with the community, as we mentioned, the school, but also the daycares who need to take care of these children with special needs. The county waiver system, who's paying for this, and how can we make sure that the children and their families get the help that they need? And the extended families. Many times it's grandma or a cousin that perhaps helps out. But there's also others involved as well, as a religious community or other volunteer organizations. Our goal is to really have good continuity from the hospital to the clinic to home to other. The other might be a foster care, it might be a rehab facility. But through this whole time of continuity, we want aggressive pain and symptom management, good care coordination, and psychosocial support so that we can make sure that the children and the family are getting the care that they need. But again, what does this look like in real life? I want to tell you about Danny. Danny was born to a professional couple, and they had been infertile for a while and had really struggled with that. Finally, they got pregnant and had this beautiful little boy. And at 4 months old, he started to fail his milestones. And you're like, really? Can a 4-month fail at anything? They're really good and successful at keeping parents awake. But he was failing at his milestones. They took him to the university. They did lots of tests, figured out that he had a neurodegenerative disease. And the parents were just devastated. But he came onto the hospice program, and they were expecting him to die. But he didn't. He reached his 1st birthday, and he reached his 2nd, and on till his 5th birthday. And his 5th birthday, we had to start looking at school, and what does that mean, and how do we move forward with that? And in 2013, I went to his 18th birthday party. This is Danny. He can blink his eyes yes and no, and he gave me permission to share this story with you. So for when we look at pediatric palliative care or serious illness care, we need a model that's flexible. We can't work with a hospice, palliative care, home care model. It needs to have this flexibility. Danny came to us in hospice, but soon he moved to palliative care and onto complex medical conditions. So we need to have a system that's going to work for these children, and that's what we've developed in our program. Our program covers 13 counties, but what about, or 16 counties, what about the rest of Minnesota? So we do reach out to rural Minnesota. As you know, in Minnesota, we get a little bit of that white stuff that comes down. And in-person visits are not always workable. So we're working with who's there. Either the family, we make sure there's a family member that can support the broader family, either a public health nurse or EMTs. Sometimes, as we mentioned in another presentation, the EMTs will be the first ones to go out and help set up the medications or the equipment. And the distance support for telephones, by telephone, email, or video visits. Often we ask our rural colleagues to help with a pediatric case, and they may be worried about it. Oh my gosh, I haven't taken care of a peds. But if we can do co-visits with them on a video visit or encourage them through email and phone, it makes a big difference. We had a situation where the rural nurse had asked us to do a co-visit for the video visit, and the video was turned on the little boy who was sleeping, and we were talking, and those of you in palliative care know when you have these difficult conversations, you go a little bit and you see kind of what the reaction is of the person, and then you go deeper. And so I was doing this conversation, but I couldn't see the mom, and so I said, can you turn the camera around? And here the mom was crying. And so unless we have that visual, sometimes it's really hard to do those co-visits. So email and video visits, telephone, all work together. Then we have a strong collaboration with our state association. Many times the rural programs will call the state association saying, we're getting this child, we don't know what to do. And so they would connect them with people who can support them. But how do we do this work? How do we find staff and keep them in place? Really getting that awareness of need. When we got the first federal appropriations for doing pediatric palliative care education in the 2000s, we were calling around the counties, and I called one in rural Iowa, actually, and I said, she said, I don't think we need it here. And I said, really, what do dying children do, or children with serious illnesses do in your county? And she said, I don't think we have any of those in our county. And I said, wow, I think I want to go live there. That sounds like a really nice county to be in. So really developing that awareness of need, and then training and education to make sure that the staff who are there are able to provide that good, competent care, and that they get the care that they need, that self-care is done. For our staff, many of our staff work alone in the home. They all have self-care plans that they need to make out, addressing the 4 domains of self-care, and to have accountability partners. So my accountability partner is usually a social worker, and if she sees me getting burned out, she'll say, Jody, you look a little crispy. So I'm like, oh, okay, I guess I need to take some time off. But that self-care needs to have leadership support as well. It's very easy for organizations to say, yeah, do self-care, but you still need to see the same number of patients, get your documentation in, and yeah, definitely take care of yourself. But there's a snowstorm out, and you still need to see the same number of patients, but just take care of yourself. So you have to have that leadership support. And as mentioned before, good teamwork. None of us do this alone. Even if we're out in the community alone, when we come back, that teamwork is so very, very important. But teams don't just happen. They take work. And just to quote Balfour Mount, one of the leading people in palliative care, if they don't have scars, they haven't worked on a team. Teams don't just happen. They slowly and painfully evolve. The process is never complete. The work involved is usually underestimated. It does, and those of you who worked on a team know it's hard work, and it's not very nice work. Sometimes it's difficult. That clear communication is so important, and that takes time. Conflict resolution, particularly in Minnesota, we don't like conflict. But resolving that is so important. And education can't just happen once. It has to be ongoing. I've been in pediatric palliative care for many, many years, but I'm still learning, and we still have to learn as we go along. But to do this, we need adequate funding. And that funding in home care, we are paid less than half of what the cost of a visit is. And so for small rural agencies, they can't afford to do this care. If you're in a big healthcare agency that can absorb the costs or make up the money by the test, but if you're a small agency, you can't do that. So our funding really needs to be focused on provision of services at home, needs to be flexible and responsible to needs. Those of you who have children in your life know kids can be fine when they go to bed and wake up really sick the next morning and need to do an ED visit. Or they can be throwing up at 2 in the morning and be fine the next morning. So we need a flexible benefit. And we need to at least break even. We can't ask angels and wonderful people just to continue to keep giving. We have to make it financially feasible and accessible across boundaries and insurance companies. We recently had a little child that was referred to us for serious illness care, and because his insurance wasn't able to cover it, there was a big deal of negotiating of how can we do this, and we need to make this less complicated for families. So in summary, I want to leave you with another story. Nevaeh was born to a family from rural Minnesota, or rural Iowa, could be anywhere. And she had multiple congenital abnormalities. She was in NICU for a long time. They tried many, many things. But at the end, Nevaeh's little body was just too tired and too weak to carry on. And the family said, you know what? We just want to go back to our rural home. We want to take her home. We want her to see her bedroom just one time. and be surrounded by grandparents. Of course, this comes up on Friday afternoon, right? So we called the local hospice, and as rural people often do, they said, sure, we'll do whatever it takes to make this happen. So the family left NICU. They were halfway there. 4:30, the on-call nurse comes on, said, pediatric case, babies, I'm not trained in this. I can't do it. I'm not going to be put in that position. I can't give incompetent care. Family weren't going to turn around and go back. So they went home. Their family was there, and Nevaeh died that night. Oh my gosh, we don't do this to our elders. We don't do this to grandma. How can we do it to our children? We need palliative care education for clinicians, but that's not enough. We have to have accessibility to services, appropriate funding, and program flexibility. And we all want, and compassion above all. And we all want our country to be great, or to be great again, or to be great always. I'd like to quote Mahatma Gandhi in finishing, a nation's greatness is measured by how it treats its weakest members. Thank you very much.